stopped some of those individuals having the first episode of mania. So what I want to do is try and explain to you the concepts behind this and how we're going to try to do it. Before I do that, I do want to say very sincere thank yous to two people particularly. Marion Boyer for inviting me to join her team here in Paris, and David Roshi, whose generosity has allowed us to start this work. I promise not to name everybody. I realise this is not the Oscars. I'm not allowed to name everybody on the list of my colleagues, but just to say the people at Chaire Fondamental who put up with me day to day, speaking frongly, and my colleagues at the centre, particularly in Créteil, who've made me so welcome, and a lot of what I'll talk about now represents ideas that we're developing as a research group. So in order to try to explain what we're going to set out to do with young people at risk of bipolar disorders, I need to give you a bit of background about what's happened in medicine in the last century, but certainly particularly how it's changed in the last 50 years. And a good place to start is with heart disease. In the last century, heart disease killed about 35 million people. After famine and war and infection, it's probably one of the most dangerous things that could happen to people. But when we first started to try to manage heart disease, if you wanted to buy a telephone, and you'd be very lucky to have one of these, this is what you'd be using to make your telephone calls. So it's an old model. And when we started to treat people, we thought that heart disease had a single cause. It was a blockage of the arteries in the heart. It was either present or absent, and the treatment came after people were affected very badly by the disorder, I mean quite disabled. If you ask a young person today what sort of phone they'd like, I'm reliably informed they want one of these because it's next after the iPhone. So by the end of the century, we were treating heart disease very differently as well. By the time you own this model of telephone, our entire view of heart disease has changed. It's a disorder that has many causes that often come together. It's quite complex. It's a disorder where you'd be very unlucky to wake up and have a heart attack without ever having had a contact with a clinician who helped you understand you had some risk factors. And our goal is not to just treat illness, it's to try and keep people healthy and stop an illness progressing. And this model, in the past 40 years, has radically changed our approach to heart disease in medicine. And so, if we start at the bottom corner, which is the worst outcome, it's bad heart disease, it's heart failure, it's people having heart attacks. But what we now know, and this is very general knowledge, is that actually some people have a higher risk of getting to that point because, for example, they have a family history. But not everybody who has a family history gets heart disease. Sometimes other factors play a part, particularly things like high levels of cholesterol. And out of that group, they start to get problems with their blood vessels. Their arteries become hardened. So some of those individuals get high blood pressure. And if those sorts of problems also affect blood vessels in the heart muscles don't get enough blood and oxygen, so you start to get angina. And then a subgroup from there are the people who have heart attacks. Now this is now so common knowledge in medicine, we don't even think about it as a model anymore. But it's a continuum of what happens to people. And the treatment at each stage is different. Often, the treatment of people at risk of an illness does not require medications. We can change some aspects of risk by making other interventions. If people go on a diet, lose weight, take more exercise, and still have high levels of lipids, we might also give them drugs called statins, which reduce the lipid levels, to reduce the risk that people go to the next stage. So only a small group of people are getting surgery where we put tubes into the arteries to keep them open, which is the most dangerous intervention and the most expensive. And at that point is the one where the risks and benefits ratio starts to change. And what's really interesting now about heart disease is using new technologies and good clinical practice, we can start to work out who is going to shift between each stage. And with statin drugs, for example, there are some side effects from statins. We can genetically test people to see who's at risk of muscle problems related to statins. So we can actually start to work through what we call the clinical stages. So most models of severe chronic physical disorders in adults, diabetes, heart disease, have these types of models. And we can work out the point at which people might move to the next stage. We can try to treat it before it gets to the worst place. So I'm not going to go through this slide in every single detail, but just to emphasize, this is what we would call a paradigm shift in medicine. 20th century medicine was about treating an illness. It had very simple models. You either had an illness or you didn't, and we probably only had one treatment for that illness. We didn't have a range of things you could do. And it was an enormously costly exercise in terms of people's health and in terms of the actual amount of money we spent on the treatments. The new models understand illness as something that evolves on a continuum. You start from being at a level of risk, and gradually there are factors that might come into play that increase the likelihood that a small proportion of people end up with a severe disorder. And so modern medicine for heart disease is about prevention, it's about predicting where people are, it's proactively treating things before they happen, and it's called personalised medicine because eventually we are working towards finding biomarkers and genetics that will tell us who might respond to different treatments. So staging is a really important idea in medicine because it's more refined than diagnosis. It tells us about the progression of illness. It brings in new technologies in a way that they help improve our ability to understand the staging of illnesses and the boundaries between the stages, and it introduces brand new therapeutic options. And this is also very important. For example, in psychiatry, many companies are no longer interested in funding new drug developments because they don't see these sorts of models. They don't see opportunities to try and think about mental health issues in a different way. So, that's heart disease. Let's pick another disorder that killed a lot of people in the last century. Twice as many people died by suicide than by heart disease. And it's a tragic but very real issue that most of these individuals had schizophrenia, bipolar disorder, or depression. But what never seems to get pulled out of that story is that the age of onset of severe, persistent mental disorders is 15 to 25. That's the peak age. People with heart disease, the peak ages are 40 or 50. Chronic physical disorders are what older adults get. Mental disorders are what young adults get. These are the chronic diseases. And this is the point at which young people don't use the services we provide. The gap between the services and the level of mental disorders in this age group is as big as it ever gets, because the services we provide do not meet their needs. They don't even fit into what people want. And this isn't just a clinical or an individual issue. This is data taken from a study last year on economics and the global burden of disease. And they looked at the global burden of disease by age groups. And these are the top 4 ranking disorders or problems in young people that don't just kill them, but also produce morbidity, cause social problems, cause family problems, and actually are economically very costly. And 3 of them are our 3 major severe mental disorders. Now in schizophrenia, there's been a very radical change in how people have approached this disorder. Around many countries in the world, people have introduced what's called early intervention services. So beginning to get the idea of what's behind the staging model, looking for young people at risk, but very importantly, at least treating that first episode very early. No such model exists for depression yet. And that's a shame for both the reason because depression is a very prevalent problem, but also because young people who get a very early episode of depression are also in a high-risk group for people who develop bipolar disorder. Because although our target is mania, about 60 to 70% of young people who go on to develop bipolar disorder start with a depression in this 15 to 20 age group. So our goal is to start to work with these individuals to see if we can start to put together a picture of the pathway to mania. Now the difficulty is that this is the model we're still using in psychiatry. And Thomas Insel, who's probably the most important person in mental health research in the world because he's the director of the National Institute of Mental Health in America, made this very telling comment a couple of years ago. Diagnosing bipolar disorder with the emergence of mania is like diagnosing coronary artery disease with a myocardial infarction. It's too late, it's unsustainable, and it's not a model that we can possibly keep supporting. It really is that bad. It's out of date. It's last century's model. So, there is a bit of light at the end of the tunnel. We've been working with colleagues in Australia, Pat Rory and Michael Burke and Ian Hickey are some of the key people there. And this is not the perfect model, but we are starting to get a very basic model of clinical staging for mood disorders. And likewise, for people at risk of developing psychosis. It follows the same principles as heart disease, and this level between 1 and 2 is the old barrier between absent and present. Now interestingly, about 75% of the research funds in the world that go into mental health go to people in the disease present group. But sadly, it doesn't go to helping us understand staging. It just goes to help us look at how we treat those individuals. And as important as that is, we have got to try and move things forward a bit more. Probably about 20% of the money goes into looking at genetic risks. But what it doesn't tell us is the difference between people who inherit the possibility of developing the disorder and people who actually get it. And so what's happened in schizophrenia research is people have now started to shift their thinking towards these ideas of staging, and the project we're about to embark on is also trying to look at these sorts of issues. So we're not there, but we're probably here. We've got the technology. These old mobile phones, the first ones, I think weighed about 6 kilograms. But at least we had the idea and the concept. And now we need to apply the technology, the new technologies in medicine, to get us to the next step. So we have, fortunately, indeed, a grant that Marion Laurier got last year to look at these stages 2, 3 and 4, to start to understand the boundaries between them. And with the generosity of Dan Doroshi, we are embarking on a project to look at who makes that transition from being in a risk group with some non-specific symptoms in adolescence to somebody who develops disorder. And obviously, there's a range of factors we're going to need to look at, but also there's a very important set of principles behind the project, which is actually all those things I told you about: prevention, prediction, being proactive, the notion of personalised treatments, but also participation. Because this is about young people, and we need to know what it is about our services that are such a turn-off that mean they don't come and see us. And we also need their families to be involved. And also, this has a lot of implications. We need the patient advocacy groups to help us. We need the politics of this to be discussed. One of the biggest reasons mental health services in Australia are now radically changed is that all the political parties got behind the notion that investing in young people is a good idea. So, why France? You might have noticed I'm English. What am I doing here? Well, that's a good question. Well, it is the right time. We're starting to understand these models. We've got very crude staging models for mental disorders. It's certainly the right people, and that extends not just from the team of people involved in the work of the expert centres and the foundation, but I note that the new president, both before and after his election, was talking about young people, so hopefully we can keep reminding them that actually mental health of young people is economically important as well as socially important. and it's definitely the right place. My experience of working in some very good institutions is that actually everybody is doing their best, but sometimes you get to the right place by collision rather than planning. And I think what I like about my experience with the links to the expert centres is that it seems that the research and the clinical and all the other key groups are pulling in the same direction, which means the chances are we can start to improve things and move them forward a bit faster than we would with those rather random interactions that sometimes occur in research and clinical practice. I'm not going to go through this slide because this really represents a lot of the work of what the expert centres currently do, treating adults mainly at stage 3 and 4, increasingly trying to bring in people at stage 2. But the reason I'm showing you this is to say we have the infrastructure to do this project. Because, like heart disease, one of the big risk factors for developing bipolar disorder is having a family history. And so what we're going to do is approach some of the offspring of the parents at the centre to see if we can work with them. We're targeting 16 to 25-year-olds with at least one parent with bipolar disorder, and we'll be trying to pick out a group of about 150 who agree to participate in research. Now, we're interested in all these young people, but we're particularly interested in the ones who might already be showing some signs of problems. They may be struggling at school, there may be other issues for them. And the reason we're really interested in them is that actually the research data says that over 12 to 18 months, between 20 and 30% of them might go on to develop mania. So this is our chance to understand why some people keep going down a path of problems and other people seem to experience selected problems in adolescence that then no longer recur. How are we going to do it? I'm just going to give you a very brief overview of this. But the first thing is we're selecting young people 16 and above. 16 is because they can give their own consent to participate in the project. And that's really important because most of these individuals, even if they've had some difficulties, will not be patients. So this is about understanding people with high risk who may not yet have actually experienced illness. And we're trying to join up the links between the risk that might be there genetically and the symptoms by understanding these links between the cells and the immunochemistry and the systems, the neural networks that control emotions, and how these things link to risk factors that might increase the chances of following them. The second thing is obviously if we want to know more about that pathway, we need to follow some of these individuals into the future. And so the idea is to try and get at least half of these young people to agree to stick with us over the course of 2 years. With modern technology, that can be done in a number of ways without it having to be always face-to-face interviews. Some of the areas we're interested in, and Bruno Etan and colleagues are leading work on circadian rhythms, the sleep-wake cycle. If you've ever had jet lag, you will know what this disruption is about. And it disrupts not only sleep, but it can also affect mood. And in people at risk of disorder, this could actually start a process off that leads to a major episode. And colleagues in Australia have kindly given us this data, but you don't need to see this data in detail to understand that melatonin is a substance very involved in the regulation of sleep-wake cycles. And indeed, if you've been in airports in America, you can often buy it to try and treat yourself with jet lag. And this is just data that shows the red line is people at high risk of getting a disorder, but not having it. And the blue line is the reduction in melatonin that's happening in this group after they've got disorder. So there are ways in which we can try and look for markers of illness or markers of the likelihood that people will become unwell. And of course, some of these individuals will have problems. They will be starting to get more symptoms, and our goal is to start to look at how to help that as well. Again, if we take a simple example, just to try and give you a sense of this, this grey watch-looking object is what we call an actigraph. And you can use this to measure people's nightly sleep pattern, how many hours they sleep, whether the sleep is efficient or inefficient. And we know that can be related to mood change. Now, we don't expect adolescents to wear boring grey watches, but there are other alternatives. These bands are called Jawbone, and they're available on the internet to buy to wear as active watches. You can link yourself into programs. So you don't have to identify yourself as either a patient or nearly a patient to wear these things. And what we've found is if you look at mood before people become manic, it's often unstable for quite a long period of time. And the instability is often preceded by changes in sleep. Now the reason this is very interesting is because, of course, the things that we might do to reorganize somebody's sleep pattern doesn't necessarily have to be the drugs that we use to treat severe recurrent bipolar disorder. And indeed, it doesn't even need to be medication. We have other options available to us. So, a couple of final thoughts. Most of psychiatry, I'm afraid, is still practicing the absent and present model of disease. What we're aiming to do is to think a bit more about these early stages and how we start to learn how to predict who makes that transition to the later stages of the illness. We're also trying to understand what the treatments might look like and the interventions might look like for the future. And we're trying to disentangle and understand better what the treatment should be for 2, 3, and 4 stages as well. And just to prove that this isn't total fantasy, this is data from some friends in the USA where they've already done a program with young people at risk of depression and shown they can prevent the onset of major depressive episodes. And in terms of the number of people who benefit, it was as good as giving people statins to stop their blood pressure getting higher and to keep their lipid levels down. We have a manual now to do a similar sort of program with young people, but also very importantly, we're not doing this alone. We've got our colleagues, particularly our colleagues in Australia, but also through a European network, we have people who can help us. Sean Long, we have a group to help us with psychoeducation programs. We have good colleagues in the States, Holly Schwartz and Ellen Frank are international experts on working with young people with therapies that include this regulation of sleep patterns. And we also have links into what's called the Black Dog Institute in Australia and the University of Sydney, where they have many internet-based therapies and interventions that can be offered to young people at a distance. One word of caution. We can't get up tomorrow and give a new model of mental health services, and it would be very wrong of us to put this program out too widely until we've begun to understand how to make sure we've got the pathways sorted. So there will be, inevitably, a bit of a gap between how we start now and what things might look like in the future. But by my calculation, that last mobile phone is definitely 2020.